So all of us like to make the design of the brachial plexus look very complicated, and but basically what we are talking about is the wiring system that connects the brain to the upper limb. Very straightforward. What I am talking about is post-traumatic brachial plexus injuries. Obstetrical palsy will be covered separately. We are talking about injuries that can happen in a variety of ways, and the most common way is by falling on the apex of the shoulder of a two-wheeler. Now, the history is very important, because the rapidity at which the impact takes place or the arm is pulled will determine how severe the injury is going to be, and that would determine what line of action you will take for treating the patient. Therefore, any speed greater than 30 kilometers per hour is enough. One can fall off a moped and yet sustain a very serious brachial plexus injury. On the other hand, if you have a patient who has just tripped and fallen while walking on the street and sustained a fracture dislocation of the shoulder and his axillary nerve is paralyzed, it doesn't mean that his axillary nerve is ruptured. You can still have fibrillations in the deltoid, you can have a totally denervated deltoid, and yet that patient has a strong likelihood of recovery in 6 to 8 months' time, because the essential nature of the injury was at low velocity. Therefore, the speed of the injury is very important. We are talking about close traction injuries of the peripheral nerves. That means if the nerve is subjected to a pulling force at a certain degree of stretch, it will give way. And if it has stretched and given way, there is absolutely no force on earth that can connect these stone fibers in the right way on their own. Therefore, if you have an evidence that the injury took place at a certain degree, a certain speed, and you have evidence that there is structural damage to the nerve in terms of fibrillations on an EMG or root avulsions on an MRI, you have absolutely no right to say that leave this to nature, nature is going to take care of it. It is going to require surgical intervention in order to get some function back in the upper limb. So the questions that we need to answer as a postgraduate student when you're faced with a brachial plexus injury, you want to know where is the injury, how severe is the lesion, when to investigate and what investigations to offer, when do we offer surgery, what does surgery entail, and what sort of results can we expect for the patient. Now, the first thing that you must understand is what is the difference between a rupture and an avulsion. We see MRI, I get referrals where the referring doctor says MRI shows root avulsions, sir. Do you do anything in that? Now, this is a very basic question. We are saying that the brain and spinal cord have been disconnected from the upper limb. The only way you can reconnect the upper limb is when the proximal end is likely to grow. And that is likely to grow only if there is an extraforaminal rupture. That is, the injury is beyond the spinal cord, where there is an injury to the peripheral nerve. And therefore, if the roots of the brachial plexus are injured in the interscalene area, we have proximal stumps which can be connected. On the other hand, if the root itself is pulled off, yanked from the spinal cord, and there is an empty space at the level of the intervertebral foramen, it's evident that there is no proximal stump to plug it in, and therefore we would have to have recourse to other methods of connecting this brain and spinal cord to the paralyzed upper limb. One thing is certain, that if you can prove that there is a root avulsion at least at one level in the paralyzed territory, it implies that all the remaining roots of the brachial plexus have not sustained a mild injury, but they have sustained a very severe injury, and therefore surgical intervention is by default. Therefore, To recapitulate what I'm keeping on saying, if you have evidence of structural damage to the nerve and you have evidence of root avulsion, you have absolutely no business to offer non-operative treatment. Now this is my experience that I'm talking about. One thing it glares at you is that half the brachial plexus injuries that you're going to encounter are total paralysis, that is affecting all 5 roots of the brachial plexus, which implies that there is a very severe pulling force on the brachial plexus. The arm is completely disconnected from the brain, and such patients by default would require surgery if the condition does not change within a month. That means flail upper limb on first day, flail upper limb on at 4 weeks, investigate and operate. End of story. As far as, so the question whether to operate or not really applies only to the partial palsies. Now among the partial palsies, you will find most of them are supraclavicular. And therefore my focus of my first part of my talk will be entirely on supraclavicular partial palsies. So let us see the most common understood brachial plexus injury. Everybody knows Erb's palsy, that means C5C6, lack of shoulder abduction, lack of elbow flexion. You must understand here that we are losing all elbow flexors and all abductors. That means the brachioradialis also goes. If you individually examine each muscle and then look at the chart, you will find out that this is the sort of deficit that you will get. That is, you are losing all abductors, that is supraspinatus, infraspinatus and deltoid. You are losing all elbow flexors, biceps brachialis and brachioradialis. Sometimes lat dorsi and teres major is also affected, and that if you are faced with such a clinical situation, you must wait for 2 months from the accident. If you have to investigate, not before 1 month. In the first 1 month, no investigations. EMG should be specifically prescribed for the muscles that you wish to look for denervation. You perform nerve conduction studies also in a specific manner, because as I'll go on to show you, you have to examine nerves which have the same root value. And it would look, you can add an MRI which would help to locate pseudomeningoceles. Again, this is proof that there is a root avulsion, and therefore absolutely no point in waiting any further. And it will look clinically like this. That means there is trapezius action but no supraspinatus action. Latissimus dorsi and teres major were working in this patient, but let's see, this serratus anterior is not working. There is no function in the supraspinatus and the deltoid. The pec major is working fully, but biceps is not working. Triceps is working fully. And as you can see, the hand function is full. Full intrinsic and extrinsic flexion and extension of the fingers, and full wrist and palm flexion is present. That is, FCR is also present. So, if you are faced with this sort of situation, I have already told you, wait for 2 months, investigate. If you have proof that there is a significant injury, it requires surgery. Surgery implies either opening exploring the plexus, confirming the injury, and then reconnecting the brain and spinal cord to the paralyzed muscles. So either you do it using the available root stumps in the neck, or you use nerve transfers. That is, functioning nerves from outside the brachial plexus are transferred to get back specific functions, of which The spinal accessory nerve that supplies the sternomastoid and trapezius is transferred to the suprascapular nerve for the supraspinatus. My teacher, Christophe Oberlin, described this landmark technique where 10% of the fascicles of the ulnar nerve are transferred to the biceps. This was described in 1991 at the Naracas Club meeting in Lausanne and subsequently published in 1994. I had a small contribution to the literature on this in the early 90s. Subsequently, we have added using a fascicle of the median nerve as well to the brachialis, for elbow flexion, and we augment abduction by the technique described by my friend Somsak Lee Shaving Wong of Bangkok, where a portion of the radial nerve is transferred to the deltoid, and that would produce this sort of result. Restoration of elbow flexion, and restoration of abduction, with good restoration of deltoid as well, as you can see. And in addition, external rotation is full. The next more severe partial palsy would be the C5, C6, C7. And here you would lose all shoulder and elbow function. That means lat dorsi teres major would definitely be paralyzed. And you would also have lose wrist and finger extension, which would look intra-op like this and clinically look like this. That is, there is no abduction, there is no pectoralis major function in most cases, there is no latissimus dorsi teres major, no biceps, no triceps, whereas the hand remains good. So when you have examined each muscle individually and you have found out the deficit to be this way, the only place where the injury can be would be at the level of the roots. That means you have lost all function across two major joints, that the injury can only be supraclavicular. Here we again become a bit more aggressive. Instead of 2 months, we are waiting only for a month. If at that state there is no change in the clinical state, investigate and operate. Again, apart from the transfers that I have already told you, we add intercostals for transfers for the radial nerve and to the pectoral nerve, which will give us this sort of function. So the shoulder abduction, external rotation, elbow flexion and elbow extension have all been restored. So to recapitulate, C56 and C57 palsies can be brought back almost to normal. But as I said, that does not solve our problem because half our cases are total paralysis. Where the limb is completely disconnected from the brain and any movement in space depends upon use of the opposite upper limb. And the mere act of removing the shirt also becomes such a difficult exercise. However, all flail upper limbs are not like this. You might suddenly find a patient who can abduct his arm. Please do not be blinded. This patient still has a total paralysis, but the injury to the upper trunk is distal to the suprascapular nerve. And the way to be sure is to look for the Horner sign. The Horner sign correlates almost completely with preganglionic injury to the C8 and T1 roots. And therefore, as I said previously, if you have proof that there is a root avulsion at least at 1 or 2 levels, it is a very severe injury and warrants surgery. Therefore, don't expect that just because abduction is present, you have to wait for the rest of the functions to come. The presence of Horner sign implies that the rest of the plexus and even the upper trunk itself is actually severe. Again here, the waiting for a month is basically just for the edema in the neck to subside, so that surgery in the neck becomes easier. And also so that investigations actually show what you are looking for. If you are doing an MRI to look for root avulsions by showing pseudomeningoceles. The pseudomeningoceles are collections of CSF in the outpouching of the dura mater where the root has got pulled out. That can only happen when the dura mater has sealed itself, and that sealing takes 3 weeks to happen. Therefore, pseudomeningoceles will not be seen on the next day after the accident. So don't be in a hurry to do the MRI. Similarly, EMG looks for fibrillations in the denervated muscles. Fibrillations are an effect of Valerian degeneration. Valerian degeneration takes 3 weeks to install. Therefore, doing an EMG on the day after the accident has got absolutely no meaning. Therefore, wait for a month, look for the change in the clinical situation. If there is none, do the investigations and then be frank with the patient, offer surgery. If some investigation has to be done before this period of first 3 to 4 weeks, then that is nerve conduction. And the nerve conduction should be of the ulnar nerve. And why do we do that? It is because if there is a Horner sign with root avulsion of C8T1, the sensory component of the ulnar nerve would conduct electricity because the injury is preganglionic, whereas the motor component of ulnar nerve would not conduct. So that would be a relatively useful investigation in order to arrive at the diagnosis that yes, this Horner sign actually implies a root avulsion of C8T1. But an EMG certainly would not be useful. Again, at a month, do an MRI and it would definitely help you out to confirm the diagnosis of a severe injury. Now, what exactly is the surgery that we would do where all 5 roots of the brachial plexus have got pulled out from the spinal cord and you want to regain control of the paralyzed upper limb? What we want to do is to harness the growing axons at a ruptured root stump in the neck, but that is lying in the neck and your target nerves are in the deltopectoral region below. How do you bridge that defect? You bridge it by laying multiple cables of nerve graft from the proximal stump to the distal target nerve. Unfortunately, this does not function like electrical wires. This basically implies that these axons get a track on which to grow and reach the eventual target organ. And therefore, nerve surgery is really a leap of faith. You have to rely on science that was proved in 1967 by Milesi that yes, if you have a good nerve stump proximally and a good nerve stump distally and you connect that with by interfascicular nerve grafting, there is a reasonable chance of getting back the desired target after growth at the rate of an inch per month. Therefore, if you are connecting the C5 stump in the neck to the median nerve, for you to see wrist and finger flexion would take 1.5 to 2 years. So this is one method of connecting the brain to the upper limb. On the other hand, if you have no roots available, that means all 5 roots have got pulled off from the spinal cord, you have only recourse to nerve transfers or so-called neurotizations, where you harness functioning nerves from outside the brachial plexus, such as the spinal accessory or intercostals. Those nerve ends are now live wires which can donate growing axons to reach certain target muscles. However, the quantity of growing axons is small and therefore such nerve transfers can only be for specific targets such as the suprascapular nerve, the musculocutaneous nerve, and the radial branch to the triceps or the pectoral nerve. On the other hand, if you want hand function, that means it implies median nerve. Therefore, you need to have large bolus of growing axons. Such can come only from an ipsilateral root stump, or it has been proved, you can use a part of the C7 root of the opposite normal functioning brachial plexus. So let us look at the spinal axillary suprascapular nerve transfer. It is a very reliable transfer in more than 75% of cases and would give this sort of abduction. Intercostals for musculocutaneous, again relatively consistent results of 70% with this sort of result. However, when you are talking about hand function, re-innervating the ulnar nerve doesn't serve any purpose. Therefore, we have to re-innervate only the median nerve, of which I prefer to re-innervate the medial root of the median nerve. The lateral root of median nerve is largely sensory. Most of our surgery in a flail upper limb is to get back motor function, and therefore you must innervate the medial root of median nerve. This is usually done using nerve grafts from ipsilateral root stumps or using from the half the contralateral C7 bridge using a vascularized ulnar nerve graft. However, the problem is it comes after 2 years and it is very feeble and it only works in one direction, that is you have finger flexion, you do not have finger extension. So if an ipsilateral root stump can give this sort of feeble wrist and finger flexion even in such a young patient. And a contralateral C7, when she exerts opposite triceps, you can see that the wrist and fingers flex on this side. When you put all these nerve transfers together, you can get a reasonable control of shoulder, elbow, and fingers. Just for some sort of feeble function at the hand from the contralateral C7, which with the help of certain basic orthopedic operations like a derotation osteotomy of the humerus and wrist fusion can be made to a situation where now he is able to take care of his clothes in a much better manner. Or he can why is this video not running? Can I go back? Yes, go ahead. Okay, yeah. A patient with a flail upper limb with a biceps to FDP transfer can reach out and grasp objects and place them in space. Or a patient who has merely had biceps and pec major come back with a shoulder fusion and a wrist fusion can reach this sort of independence in his day-to-day life. How do I go to the next one? So finally, just to conclude, can I go back one slide please? The attitude towards adult brachial plexus injury should not be that leave it to nature. Most of these injuries are supraclavicular and supraclavicular brachial plexus injuries are severe injuries. They have to be offered surgical treatment. You can easily reach the diagnosis by simple clinical examination. Investigation should be done only after 3 to 4 weeks, not in the first 3 to 4 weeks. And if you have clear evidence that there is a severe traction injury, you should offer surgery. Shoulder and elbow functions can be consistently restored, and therefore if only shoulder and elbow is paralyzed and the hand is working, the patient can be brought back nearly to normal. Whereas if the limb is totally paralyzed, we can give a certain degree of independence to the paralyzed upper limb. I thank you all for your attention. Thank you very much.